have a lot to cover, so I know you're postprandial. You're just going to have to put it on hold. Okay? And of course, the work that I am presenting, I've done with a host of others, basically a village. And the PI of the studies is Bruce Hollis, and I'm co-PI, and we've had various funding. I have no disclosures. And what we're going to cover today, which has been covered in various ways, but it's going to be with an emphasis on pregnancy, lactation, and early infancy. So why are we deficient in vitamin D? I think many of you could answer that question, but I'd like to give it that information or that sense to you from a pediatric perspective. What is optimal and what is not. And again, my title is It's a Moving Target. So what we thought was optimal in 2000 is very different than what we think is optimal in 2010, and I suspect what we will recommend in 2020. And I'm just going to briefly talk about the link between vitamin D and long latency diseases and innate immunity, which Dr. Haney will discuss in more detail. And I'm going to end with really our data about pregnant women and making them replete or not, lactating women, and early infancy. So this is, these are baseline circulating 25-hydroxy vitamin D levels in pregnant women in sunny South Carolina, latitude 32 degrees north. So this is here, frank deficiency. We define that as levels less than 20. And this is insufficiency, levels less than 32 nanograms per ml, which would be 80 nanomoles per liter. What you find is, so there's some deficiency in Caucasians, but if you look at more than 3/4 are either deficient or insufficient. These are African Americans. 75% of our women in this pregnancy cohort of 700 women were deficient. And then if you added up the ones who were borderline, so insufficiency, virtually all African American women in sunny South Carolina. So we have over 300 days of sunshine a year, very similar to San Diego. Hispanics are somewhere in between. Again, this is all reflective of pigmentation. The darker the pigmentation, wonderful rich melanin, less photo aging, less risk of skin cancer, but it takes a lot more sunlight to get the same 25-hydroxy vitamin D level in your blood. And this is the entire cohort. So these are all pregnant women. No, this right here is throughout pregnancy. And we found no difference between whether they presented in their, these were just random levels. And I'll show you some data in our other cohort, or other cohorts where we followed it throughout pregnancy. So this speaks to the epidemic that we have. And you can imagine what it would be like if you looked at vitamin D deficiency or levels in upstate New York or Canada, or Australia, Alaska. We tend to think only in our regions where we live, but this is the best. If this is the best we can do, then we're in big trouble. So why is vitamin D deficiency so prevalent today? Well, let's go back in time. I'm a great fan of history, and I love to read what my mentors taught me so many years ago. Of course, I was about 4 years old in 1963. And they reported on the dangers of vitamin D. This was the Committee on Nutrition, and it was in the Pediatrics Journal. And it was a whole section on the dangers of vitamin D because they really were concerned that you could make everyone toxic with vitamin D. So the concern rose out of the 1950s, post-World War II, particularly the UK, that vitamin D given to pregnant women was teratogenic. And the concern that even for some individuals, doses of above 400 could be toxic. Yet, even when this report came out in 1963-64, there was no quantitative means of assessing circulating concentrations of vitamin D. In fact, at that time, it was really unproven that vitamin D was further metabolized within the body. By 1967, vitamin D was viewed, certainly by the pediatric community, the medical pediatric community, as a significant causative factor in supravalvular aortic stenosis, or SAS, okay? And these were by the giants of the field. So be careful of giants, because what I say today may be heresy tomorrow. But so Dr. Tausig, Dr. Friedman published in very well-revered journals, and they mentioned that vitamin D was a causative link with SAS. The premise was that maternal vitamin D supplementation during pregnancy caused the syndrome, or at least was strongly associated with it. We can't prove causality, can we? There were elfin facies and other findings were described. They also developed animal models to prove the point. And if you look at what they were doing, they were giving pharmacologic doses of vitamin D. Hundreds of thousands of international units were given to various, typically a rat model, to create hypercalcemia. So what we were to find out, that SAS was not caused by too much vitamin D per se, but in fact is a genetic disorder called Williams syndrome. And it's a severe genetic affliction related to the elastin gene. There's disruption of that gene, and you can see specifically there's a deletion of elastin in contiguous genes on chromosome 7G11.23. It's characterized by multi-organ involvement, including SAS. You see the elfin facies, and you see a distinctive cognitive profile. So there was misattribution that vitamin D as the cause, or certainly the strong correlation with SAS. And it's true that Williams syndrome patients do often exhibit abnormal vitamin D metabolism, and they have an exaggerated response of circulating 25-OHD to orally administered vitamin D. And they're susceptible to bouts of idiopathic hypercalcemia. And really, this relationship was suspected as early as 1976, but it wasn't proven until we developed the technology, and we see that reference. So that was the first, was that there really was an enormous concern about vitamin D and the toxicity, the teratogenicity. The second problem is what really constitutes sufficiency. And I think you've heard throughout the day that, that's, again, a moving target. And it may be that what's correct for, one group of people may not be correct for another. So as I say here, even today, we really don't know what sufficiency is. And certainly, if we don't know it in adults, we know far less in children. And yet we should, because they are growing and they're setting the stage, certainly for long latency diseases. And of course, there was always the view that you only needed vitamin D for growing bones, and that's about it. And the premise was that all you ever needed you could get from one glass of milk, which we all know has about 100 international units, give or take 50% deviation. Or you could just stick out your arm or your face, while you're driving to and from work 3 times a week. And then how do you define it? If you're an office worker, and this is my colleague Bruce Hollis's slide, covered in sunscreen, you're inactive, and you have general sun paranoia, then your levels are going to be 2 to 15. So is that normal? Do we define it as the absence of disease? How about a field worker, or a lifeguard, or a pregnant woman and her developing fetus, or a lactating woman and her breastfeeding infant? And children throughout childhood and adolescence. Really, what do we want? What's optimal? Well, if we go back in time again, Haddad and Chu had published this paper in 1971, and they were looking at those they were basically testing an enzymatic assay. And they had a group of normal adult volunteers, so they defined normal as absence of disease. They had 4 patients with biliary cirrhosis, and they had 8 lifeguards. So they wanted to have the spectrum. And so they were able to show that. Well, this became the basis for what we considered normal distribution for vitamin D, and I said, okay, 2 standard deviations, to the left of the mean gives us those people who are deficient. And it really was not powered to do so. Can you imagine in 2010 actually trying to show what's normal based on whatever 52 individuals? That would be laughed out of any journal. Yet we extrapolate, things come through the back door. How many times does that happen in medicine? So really, normal vitamin D status should never have been defined by Gaussian distribution. And again, the threshold, looking at the curves you'll see later, you'll see what I mean. And it would be, again, to quote Dr. Hollis, defining normal estrogen levels by sampling a population of women who are postmenopausal. You would just never do that. So if it's so obvious in that example, why is it not obvious with vitamin D? I don't know, you tell me. So the range of what's associated with better health, where there are higher rates of disease versus lower rates of disease. I think we know that. We know that now. We didn't know that 5 years ago. And then the third problem that's really influenced this epidemic that we have is our use of sunscreen and lifestyle changes. Now, sunscreen, again, came through the back door. Can you imagine if you had the ability to block a hormone in your body? Do you think the FDA would have regulated that a little bit more if we'd known really what it was? So this was a study done by Matsuka et al., and she's a dermatologist, I think retired, but out of Philadelphia or Pittsburgh. And in this study, they looked at the sunscreen. So you cover various amounts of your body. So these are the areas not covered. And what you can see, this is no sunscreen, and this is full sunscreen, and this is a SPF of 8. And again, the surface area is what really determines your synthesis of vitamin D in the skin, and this is the y-axis is serum vitamin D3 in your blood 24 hours later. So head, neck, arms really do very little, so you're riding to work to and fro, especially since usually you're going to work and driving home, not during peak sunlight hours. So that's one thing. And then adequate intake for vitamin D. Everything's been based on that 1 teaspoon of cod liver oil. And so they said, okay, kids don't get rickets if you give them 1 teaspoon of cod liver oil a day. We know it has about 400 international units. And so then the Institute of Medicine said, well, a generous allowance in adults would be 1/2 of that. Because again, if you're not thinking of vitamin D as a pre-pro hormone, you're not going to, and you don't know that it does all these other things, that's what you're going to recommend. These are not bad people. These were people who are well-intentioned, and we must always understand that. And as I sit here, I'm humbled by history. So someone probably 10 or 15 years from now is going to say, you know, when Wagner or whatever et al. Said such and such, well, I think that, you know, we should remember that. And then the other event that has happened, so sunscreen and then the way we live has changed. So the Indoor Air Quality Act of 1989, what did that have to do with anything? It had to do with the fact that the government realized we spent more and more time indoors, and they had to regulate the quality of the air we breathe. So they actually surveyed how much time Americans in 1989 spent indoors. That was before the widespread use of air conditioning, so just Many homes didn't have that in 1989. And we didn't have computers and iPads and iPods and video games. But we spent, in 1989, 93% of our time indoors. That's 22 hours a day, and it's far worse today. I think Dr. Haney said something about the average child spends like 6 minutes outside a day. So we know what determines your vitamin D status, a whole multitude of things: degree of skin pigmentation, sunlight exposure, dietary contribution. Unless you are a traditional Eskimo, you get less than 10% of your vitamin D. Where you live, so the latitude. We always talk about the northern hemisphere because we're ethnocentric or ethno-latitude, whatever. But the same applies to the southern hemisphere. The farther you are away from the equator, the less likely you are to make vitamin D, particularly in the winter. So season, use of sunscreen, protective clothing, outdoor exposure, and not surprisingly, when you think about Americans and body mass index. So the fat stores become a sink for vitamin D. So that's for an adult and children. What determines your vitamin D status if you're a fetus or a neonate? And we know that the neonatal levels are about 0.6 to 0.7 of the mothers. And we looked at that in 100 cord blood samples with a mean gestational age of 37 weeks gestation. So full term is 40 weeks. And we found, of course, differences between, this was a African-American Caucasian cohort, and we found that there was seasonal variation in Caucasian, but not so much in the African-American population. And again, this is at 32 degrees north. So we have this whole concept that there's substrate deprivation, that you don't go out in the sun, you don't get it from your diet, and if you do go out in the sun, you cover up. And so what we're seeing is really low levels across the lifespan. And when we think about it most carefully, we realize that vitamin D is the only endocrine system in the body, the only steroid endocrine system in the body that is almost always limited by substrate availability. And again, due to a multitude of factors, it's going to influence your vitamin D conversion to 25-OHD and your 25-OHD conversion to 125. And this is Dr. Veith's slide, and I don't know how many other people, you've probably seen this, it's quite famous, but it shows where old world primates, what the levels would be, certainly well above 80 nanomoles or 32 nanograms per ml. And if you're in, you actually go outside, so a field worker, you're going to have levels comparable to that. So this is what normal was defined as for more than 30 years, and clearly well below how we evolved. And that's what you would achieve, where your levels would be on 1,000, generally speaking. And this would be on 4,000. So it takes at least 4,000. And again, there's a great deal of variability. It depends on your body mass index and other factors. Clearly, your GI tract is a very complicated organ. Stages of deficiency, we don't really have time to go through that, but you can look at the website later on. It's the same in with children, of course, it will manifest as rickets if it goes unchecked, whereas in adult, it's osteoporosis. I talked about calcium absorption this morning, so I won't go into that. When you say vitamin D, ask anyone on the street, vitamin D deficiency, rickets. I mean, I would say probably 95% of the population can say that. But more recently, there's been this whole movement afoot to study vitamin D's effect on immunity and the interaction between that. So here's this girl. This was actually Dr. Lyndon Key, a patient of his. He's a retired endocrinologist at MUSC. And this was his patient whom he followed. And She had rickets at 14 months and then was followed at 11 years old. You can see that the bony deformation with becoming replete with vitamin D is corrected, but we have no idea what vitamin D deficiency early on in this child's life has done to her risk factors for the long latency diseases. So we can talk about, breast cancer and multiple sclerosis and all of those things, but remember, those adult diseases have their origin in childhood. So I speak to you as a pediatrician and as a neonatologist, and if we're going to impact, we've got to go to the source, to the earliest ages. So how toxic is vitamin D? We certainly know that the current recommendations, which are going to be revised and will come out, I think, in May, say 2,000 is the upper limit. Yet we have history again to help us. In Finland, children had gotten up to 4,000 and 5,000 international units a day without any reports of infantile hypercalcemia. And they followed these children 30 plus years later and found that the risk for type 1 diabetes was significantly decreased. And I think Dr. Haney will go over that. So we have landmark studies that allowed me to be able to talk to you about pregnancy and lactation supplementation. Reinhold Vieth and Dr. Haney. Without those studies that are listed here, we would not be able to give anything above 2,000. And it really is to their credit. And that was the first step in 1999 and then 2001 and 2003 to really look at what is safe. Dr. Gordon in Boston looked at supplementation of children who had low vitamin D and compared 2,000 international units a day of D2 to 50,000 IUs of D2 weekly versus 2,000 D3 a day. And what she found was really no difference between the treatment regimens, that she could make them replete, and what you see is PTH dropped. There was no really minimal change in serum calcium levels. So as a clinician, as a therapist, you do have some choices on how to supplement. And when compliance is an issue, and again, you have to take into account the culture and the views, the attitudes of your patients when you prescribe. We've gone through biomarkers of vitamin D sufficiency, 25-OHD, intact PTH, bone mineral density, intestinal calcium absorption, mobility responsiveness, insulin sensitivity, beta cell function, immune function. And then again, whether or not you can use long latency diseases, I think you can, as a marker of vitamin D sufficiency earlier in life. There are a whole host of associations between, acute and long latency diseases, and you mentioned them. I'm going to highlight fetal growth. It was known from the 1980s, fetal growth, fetal dentition, and bone mass were associated with the risk was higher with lower rates, lower levels of vitamin D. So what do these diverse groups of disease states all have to do with vitamin D? And I think that's an essential, pivotal question, and you need to think about it. So, and it really goes back to this vitamin D syndrome, absolutely. I think that it manifests in very different ways, but it's all connected to the immune system. And again, history helps us. In 1903, Niels Finsen was awarded the Nobel Prize for his work demonstrating that ultraviolet light was beneficial to patients with lupus vulgaris, which is the skin manifestation of tuberculosis. And it was known for years that if you put patients with tuberculosis outdoors, you would cure them. So sanatoriums developed. And then what went wrong? Well, we blocked the ultraviolet B with glass, right? And so then they fell out of favor, and we developed the whole antibiotic era was shepherded in. So the landmark study, Liu et al. With cathelicidin It's an endogenous antimicrobial peptide. It's generated by the innate immune system, acts through TOL2 surface receptors. And so Dr. Hollis and our group at MUSC provided the researchers up north with sera that were taken from very deficient African American subjects who had very low 25-OHD. And what they found that it was insufficient in supporting cathlicite and mRNA induction. When you added 25-OHD back to those samples, it restored the ability of the sera from these African American patients to mediate the induction of cathlicite and mRNA. So this paper is, I think it's been quoted, referenced over 500 times. It supports a link between toll-like receptors and vitamin D-mediated innate immunity. There's more work being done with adaptive immunity in vitamin D. I think in the next 10 years, you're going to continue to see more exciting work. It suggests differences in the ability of human populations to produce vitamin D may contribute to susceptibility to microbial infection. It also explains the early findings that we knew, really, for centuries, that rickets and infection were related. We knew that kids with rickets had higher rates of respiratory infections. So let's move on to vitamin D in pregnancy. So there was much consternation when Nesby Odell came out with the NHANES 3 paper in 2002 from the CDC that showed that vitamin D deficiency was not limited to children. And in fact, 42% of African American women in this large national cohort had vitamin D deficiency. That was defined as less than 15 nanograms per ml. And about 4% of Caucasian women. So what was known in 2002? Much less than we know today, that a subset of pregnant women had or developed vitamin D deficiency during their pregnancy, that they had adverse effects, fetal dentition growth, lighter, less dense bones, and rarely neonatal seizures from profound hypocalcemia. That if you supplementation with vitamin D beyond 400, this was the dogma, beyond 400 was unnecessary and risky. Remember that teratogenicity data I showed you? And the Scientific Review Committee at NIH thankfully reviewed a grant that we put in where we actually wanted to recapitulate what happens by giving oral vitamin D supplementation, what recapitulates what happens in the sun. So basically give them physiologic amounts of vitamin D. And it began a cascade of events that changed the way we view vitamin D today. So again, remember those epidemic, our data from sunny South Carolina. And since then, people have reported there's a higher risk of maternal preeclampsia as related to vitamin D status, impaired fetal growth, impaired dentition, increased risk of gingivitis and periodontal disease, and a whole host of other things. In order to do the study that we did, we had to, for the first time in the history of a vitamin, apply to the FDA, and they said, we want you have to apply for an IND. So that's, and I know this, 66,346, that's our number, that's our IND. It took 4 months of backbreaking work to summarize the data, and at that time we summarized about 100 papers. You can imagine if we had to summarize it today. But it basically was required to conduct research in the US because we were using high-dose vitamin D supplementation therapy. And it really underscores the fear among the scientists and the medical profession of giving vitamin D to pregnant women. So eventually our first patient was enrolled January 2004. We enrolled 510 women. They were randomized to one of 3 treatment groups, 400, 2,000, 4,000 IUs, vitamin D3 per day. They had monthly vitamin D levels, 25-OHD levels, 125, calcium, phosphorus, serum creatinine, urinary calcium creatinine ratios were monitored. 336 women, actually 350 delivered, and then we followed and some of them moved away or whatever. So we followed 336 women to 1 year postpartum with their children. This is really important. I want you to listen carefully, so if you're postprandial, you gotta wake up, okay? There were no adverse events related to vitamin D toxicity, okay? No hypercalciuria and no hypercalcemia. That's really important. We did not see SAS. All of the women had ultrasounds at 20 weeks gestation, so level 2 ultrasounds. And we completed the last patient in July 2009, and now we have a plethora of data, so if anyone wants to come to Charleston and help us analyze it, you could be there for years. I'm also going to present this data in 2 platform presentations at the Pediatric Academic Society's meeting in Vancouver. So here are the graphs. So this is, and you'll notice that some of the points fall here because some of the women, the numbers fall off between 36 and 40 weeks because we, if they went into labor, we didn't, we got levels at delivery, but for some of the things you'll see that they dropped off. But anyway, if you look at from 12 weeks to 36 weeks, which is most representative, you see control 2,000, 4,000 IUs. This is vitamin D3. So not surprisingly, this is 400, doesn't do much. This is 2,000, and this is 4,000. Okay, then this is 25-OHD. Again, the same pattern. This is 125. We know that 125 goes up during pregnancy, and it went up really irrespective of 25-OHD, but certainly did go up more in the 2,000 and 4,000 IU groups. This is also important. This is another wake-up slide for you. So you see virtually no difference in the serum calcium levels in these women. Okay, it's really, really important. And this is PTH, so this is the 400. You would expect to see higher PTH levels in those women in the 400. There's also a trend during pregnancy where you see increased PTH. And this is 4,000 in the 2,000. This is serum creatinine, tends to go up in the last few weeks of pregnancy, and urinary calcium creatinine ratio. So we had, and we were monitored. We had our Data Safety and Monitoring Committee reviewed all of our data quarterly, and we were overseen by the FDA. Phosphate levels. Okay, this is a relationship between, so here's vitamin D3, and so if this is your vitamin D3 level, this is what we found with circulating 25-OHD. And again, everything here, this is nanomoles per liter, so if you want to get it into nanograms per ml, which is really much easier for me, but you have to divide by 2.5. And so you see that there's a threshold above which it's quite stable. Again, looking at 25-OHD and 125. Looking at 25-OHD and the urinary calcium creatinine, you'll see less dumping of calcium when a woman's really, really deficient. And then PTH, a negative trend. So the preliminary data from our NIH study, when comparing the control group to the 2,000 and 4,000 IU groups, there were significant differences on the following parameters: total circulating 25-OHD at visits 3 to 8, 125, preterm labor and preterm delivery. So when we combine those, overall infection. The increase from baseline of mothers' levels was greater in the 4,000 IU group compared with the 2,000. Comorbidities of pregnancy, what do I mean by that? Gestational diabetes, pregnancy-induced hypertension, preeclampsia, infections. So when you lump all of those together, you find that in the women who were on 4,000 IUs compared to 400, their risk of these comorbidities of pregnancy was half. And the women who had the comorbidities, their circulating 25-OHD levels were 33.4 nanograms per ml, and I'm sorry, I should have converted that. And then those who did not have the comorbidities, 39. And this remains significant after controlling for race. There were no differences, as I showed you, on the safety parameters. We also did a study in a community health center, 2 community health centers in Columbia and North Charleston, trying to see what would happen if you take a group of women who are very high risk of vitamin D deficiency, and they were all randomized either to 2,000 and 4,000. And we found the similar findings. We didn't have the 400 IU group. We felt at that time when we started this study that it would have been unethical to not supplement the women. Again, you see the baseline racial difference. You could increase their levels, of course, more so in the 4,000 IU group. And if you looked at pregnancy complications, if you looked at as a function of their baseline 25-OHD, their chronic level, or 1 month prior to delivery, we found that any rates of any infection were inversely related to all 3 measures of vitamin D status, an effect that persisted even after controlling for race, and similarly for preterm labor, preterm birth. So these 2 separate studies, and actually were 2 different biostatistical teams, we found the same. And when you look at, again, the comorbidities of pregnancy, we found similar. I think that's important. For our NIH cohort, we followed them to 1 year, and at 12 months postpartum, we found that the mean maternal baseline 25-OHD were lower in those who had a cold or upper respiratory tract infection in the last month. And we found perhaps the greatest interest, the mean baby baseline 25-OHD levels were significantly different between the 2 groups. The no group had a mean of 25.9, and the yes, saying they had a cold, was 21.9. So there was a trend, and again, I think we're now following these babies out for another 3 years through a grant from Thrasher Research Fund. So let's switch a little bit to vitamin D and lactation. So the dogma of the 20th century was that it was widely known that human milk is deficient in vitamin D. Everyone said that, it was just known, and you had to supplement children. Now, do you really believe that? Do you think that we evolved as human beings with milk that was deficient in vitamin D? I find that very difficult to believe, and probably one of the reasons why I didn't accept it. But be that as it may, we're kind of stuck, and we have to have science to dissuade people. So the AAP report came out in 2008, where we went back to the 400 IUs a day, and this took 2 years to write, and there was a lot of negotiation. And it was supposed to be just prevention of rickets in infants, so then we extended it to children and adolescents. But it's a moving target because we don't really know what the optimal dose is for children and adolescents, or any, really, for that matter, throughout the lifespan. So beyond current recommendations, the AAP recommends that all breastfed infants receive vitamin D supplementation starting within the first few days after delivery. Dr. Haney showed you that no one's doing it. It addresses the infant but not the mother's status. So could maternal supplementation at higher doses actually provide adequate levels to the mother, levels in her breast milk without toxicity to the mother that would effectively treat mother and baby? And so we asked this question. It was based on Kinsella's work in 1986, where they showed a direct relationship between the vitamin D content of mother's milk and the vitamin D status of the mother. So Greer and Marshall published in 1989, available evidence indicates that if vitamin D status of the lactating mother is adequate, her breastfeeding infant will maintain a minimally normal vitamin D status. Well, again, it's all reflective on mom's status. So we had, those wonderful studies that I mentioned by Dr. Veith and Haney, and we were able to do a study that was published in 2004, we looked at vitamin D requirements during lactation, giving women either 2,000 or 4,000 IUs. And what we found is that, so this is what we were able to increase the levels, 2,000 to 4,000. We gave the mothers vitamin D2, okay? Because we wanted to show that what was getting into the milk was really what we were giving the mother. And so the women were on a prenatal vitamin of 400, which is what they get, and then the vitamin D2 is what we gave them. And what we found, of course, that we could increase it. Now, we wanted to then we did another pilot study, and women were randomized to one of two treatment groups, either 400 or 6,400. We chose 6,400 based on the pharmacokinetics and what we had earlier found. And if the moms were on 6,400, the babies were on placebo. And if the mom was on 400, the babies were getting 300. And at that point, when we did this study, remember the AAP recommendations were to give infants 200. So we chose something a little bit, challenging. We gave 300. Surprisingly, there were no adverse events in any mother or infant related to vitamin D. Are you surprised? Okay. We found that compliance with the regimen was higher in the moms than they would admit. They said, oh, we hate giving those vitamins to our babies. And so they were more likely to forget to give their infants the vitamins. And we would weigh everything and do pill counts, which are notoriously, they can dump them down the toilet, but still. But I want you to look at this. So this is the 400 IU group. Moms got 400. This is their 25 OHD levels. So you can imagine, right? So these are the levels, and that's what had been published, and this is a 6,400. And we started in the fall and went through the winter. We wanted to see, so you see some seasonal variation there. But this is important. This is what's reported in the literature. This is the 400. And so, of course, you'd say there's minimal amount of vitamin D in breast milk, right? That proves it. So let's end this discussion and I'll go home. But in fact, what we found was you could increase significantly what was in the breast milk. And then lo and behold, this is what you see. So these are the babies who were getting 300 IUs a day. And this is what the babies whose moms got 6,400, they got placebo. So it was virtually identical. So that became the basis for our current NIH-funded lactation study. So the results of the second pilot study showed that vitamin D supplementation of mother with higher doses improved maternal vitamin D status, and in so doing increased her milk anti-ricketic activity, and thus the transfer of vitamin D to her nursing infant. But we're talking about 12 moms and babies, so you can't, again, that would be as bad as the Haddad and Chu and saying, okay, let's do it for everybody. So we showed both efficacy and effectiveness, but we have to show safety and effectiveness. So that's the study that we started in Charleston and Rochester, New York, in November of 2006 in Charleston, January 2007 in Rochester. We're about halfway through, and women are recruited. So if you know any women in those two cities who are breastfeeding, please have them call. And we followed them for 6 months, and we recently ended the 2,000 IU arm. So all these women get 400 plus 6,000, so 6,400 or 2,400 or 400. Because we found that there was an increased number of treatment failures in the 2,000 IU group. Compared to, so there were about a third of the babies in the 2,000 IU group had levels below 20 at 4 months, compared with 5% in the 6,400 and 6% in the control group. So another study that we just published, effectiveness of oral vitamin D supplementation in breastfeeding infants. We're using a one-drop solution, and people said, oh, you don't even know that that's efficacious. So we published the study in the Journal of International Endocrinology last month, and we showed that, in fact, you can increase the levels, and I will, so. And the other point is, and I'm running out of time, so I just, if you want to look at that more carefully and read the paper. But if you look at these are the baby's weights. Of course, they were growing, so they're healthy, exclusively breastfed babies. And you look at their total circulating 25-OHD levels, so they increased and stable, really. And then if you look at the international units that they were getting, and this is these were babies getting 400 IUs a day. And what you find is even though the IUs were per kilogram were dropping, their levels were maintained. But beyond that, what happens beyond 7 months? That's really the question. And so we showed that this one-drop solution is efficacious. So in summary, for pregnant women, we found 4,000 IUs a day. It was safe and effective in raising maternal circulating 25-OHD levels. It was associated with a lower risk of preterm labor, birth, and overall infections during pregnancy in both our studies. The issues remain about non-adherence and non-compliance. For lactating women, the verdict still isn't in, but you could check maternal 25-OHD levels. If you found her level was 60 or greater, then there is likely no need to supplement the baby. However, you can't assume sufficiency because we know that there's a great deal of variability in levels. So my recommendation is to check a level. You really, again, have to know that supplementing lactating women with the high-dose vitamin D does treat both the mother and infant, but it's still considered an experimental and unproven therapy at this time. But you as a clinician can treat the individual patient. I just can't say that on this platform. And to achieve circulating 25-OHDs of at least 30 nanograms per ml or 80 nanomoles per liter, probably even 40, and you can't forget yourself, so when in doubt, check a level. For the breastfeeding infant, continue to supplement with 400 IUs. There are various preparations that are effective, and combination-fed babies need to get supplemented as well, which Dr. Haney had shown as that in that study that just came out. Exclusively formula-fed infants don't need to be supplemented with vitamin D if they're taking in greater than 1 liter of formula per day. And of course, more research is needed. Indication for measurement, well, when you suspect nutritional deficiency, so virtually all African Americans, 2/3 of the Hispanics, and then anyone who's not going outside, who's sunscreen, if you're on chronic anti-epileptic drugs, have intestinal malabsorption syndromes, and if you have limited exposure to the sun, which remember, 93% of us back in 1989, seems like 1889. And if people have limited intakes of vitamin D, or they're homebound, darkly pigmented individuals, and again, I mentioned sunscreen. So in conclusion, this is truly my last slide, I promise, where I think you'll agree we're in the midst of a vitamin D deficiency epidemic. There are many reasons why, not the least of which is that we made too many assumptions about vitamin D. And it's quite likely that chronic nutritional vitamin D deficiency puts all of us at risk for developing debilitating long latency diseases. And we, society, will need to understand the role that vitamin D plays in health. This is this forum right here, so I know you'll agree. That really has to go beyond bones and mandate policy changes at the national level. That mechanism of change, of course, begins with you, begins with me. Thank you.
My question is about autism. Wondering what your thoughts are in relation to pregnant women and their circulating 25 hydroxy vitamin D levels, and then, subsequently their children in terms of development of autism. Thank you.
I think that autism, as I see it, is a multifactorial problem. And I would like very much that it would be a simple solution as vitamin D supplementation. I think that for our cohort, we're following the children to 5 years, but if you think of the frequency of autism, we will probably see a few. We will look at that. I think other studies need to be done, and I know that there are several investigators throughout the country that are looking at that. One group in Emory is specifically trying to address autism, the link between autism and vitamin D deficiency. And again, we're going to have really rigorous science to answer that question. And I don't know if someone else would like to add anything to that.
Yeah, hi, Dr. Wagner. Mark from ZRT here. We're looking at doing blood spot, vitamin D, and progesterone with the CDC in a study looking at just that preterm birth issue. And I was wondering if in your study you guys are measuring progesterone to try to pull that out of the data in terms of potentially someone who is replete in vitamin D but has a preterm birth more because of lack of progesterone throughout the pregnancy. Oh, and when you're done, somebody wanted you to repeat your website so they could grab it, if you would.
Oh, I'm sorry, and what was the last?
Oh, somebody wanted your website to be repeated if you could before you quit. They wanted your address.
My website? Oh, I'm not sure I have a website, but if you need to contact me, someone can see me afterward. But the question about the blood spots, it's great. We've actually been able to get vitamin D levels using the blood spot method in infants where if you can't get blood. So ZRT Labs has assisted us in that. And we have not looked at progesterone in that group. I think that's an excellent idea. And certainly we can analyze the thousands of blood samples. And many of those graphs that I showed you, there were over 2,500 blood samples for that. So I think that's a very good question.
Do you guys have samples of those left to analyze in future studies?
Yes.
Oh, okay, great. Thank you.
One more question from a fellow scientist.
Well, I was just going to amplify on a statement that Dr. Wagner made. Bruce has told me that 25-hydroxy-D doesn't transfer into the milk, and so in order for the mother to adequately nourish her child, she will have to be taking the D regularly because there's a short half-life of serum D, and if she skips a few days, then she'll have D-free milk again, basically. Whereas she'll maintain a good level of 25D, but 25D doesn't transfer into the milk. So that's an important clinical point, I think, to stress.
Absolutely, yes. Yeah. And Cancella, I glossed over those slides, but that showed that as well. It drops off dramatically after 24 hours. Thank you.